This is the Functional Rehab Podcast with your host, Dr. Ashley Mack.
Let's talk about knee replacements. It's one of the most common orthopedic surgeries that happens in the US, and it's something that becomes a little bit more prevalent as we get older. And so rather than me trying to walk you through the recovery process and what to expect, I thought it'd be a great opportunity to actually have another expert all about knee replacements. And so today I have Tony Maritato, physical therapist and knee replacement extraordinaire. So Tony, it's so great to see you. Thank you for being a guest today.
Ashley, thank you so much for having me. You know, I don't get to talk about what I do in the clinic enough. And so this is a great change of pace. I'm excited.
Yeah, it's really an honor because I've been following your content for a long period of time, and you do a really great job from like a business perspective, but also I look at it as you can't have a successful business unless your product or your service is actually really good. And I think that's where a lot of businesses kind of fall through as they scale and grow. Sometimes the quality doesn't really stay consistent just because of either their processes or the way that they hire people. And so to be able to see what you've been sharing, especially in the total knee replacement space, I really appreciate it. So thank you. So for the listeners out there who may have just met you today, tell us a little bit more about yourself and what you do.
Yeah. So like Ashley said, I'm a licensed physical therapist. Some of you might have heard about me. I've got a YouTube channel. We're just about to cross. In fact, today we should cross 50,000 subscribers. But the YouTube channel is 100% dedicated to post-surgical care after a total knee replacement. My background, just briefly, I had a bachelor's degree in kinesiology. I was a strength and conditioning specialist. I grew up in Sarasota, Florida. And I just love the mechanics of the human body. I love the way we move. I love the way we function. And so coming out of a heavy biomechanical background, moving into physical therapy, moving into rehab, I had a great fortune of treating a lot of different patients, but the passion for me kind of fell into individuals who had a knee replacement. And I think it's mostly because those people were suffering, not just from the surgery, but suffering through the rehab. I'd get so many reports of patients who would be in tears and they would be crying and they would get set back and they were making progress and then they overdid it in therapy and they would have a flare up and, literally thousands of stories. I've got a total knee replacement support group on Facebook with 13,000 members. I get to hear a lot of stories, see a lot of experiences. And so I felt the calling to that specific demographic because I felt like I brought kind of a practical approach. I'm not going to say I'm the best researcher. I'm not going to say I'm an expert. I'm just going to say I bring a real world practical experience to the recovery process, and patients seem to respond in a positive way.
I really appreciate that. I think it's important for us as healthcare practitioners to actually be able to provide like a true practical approach, because the reality is the fact that we live and breathe our job, so we know everything about anything in regards to these procedures. But in regards to the patient's lives, this recovery is kind of just like a blip throughout their entire living story. And so for them to have to go through this long grocery list of things to do, and if it doesn't necessarily make sense to their life, it's really hard to actually apply it into their day-to-day activity. And I see it all the time too, especially when I am in fact working with my patients who have a knee replacement as well. So let's talk about the knee replacements themselves. Before we actually get into how people recover from it, what are some of the main reasons as to why someone would actually need a knee replacement?
Yeah, that's a great question. I get that question a lot. I'm going to kind of go counterintuitive for a lot of people here. And I'm going to say, if it's pain alone, that is probably not the best reason to get a knee replacement. And I'll see family members, I'll see friends, I'll see patients. They'll come into me before having a knee replacement. They'll be scheduled, they'll be ready to go. And I'm like, well, what's going on? And they're like, oh, my knee just hurts so bad. And I'll ask them to show me specifically where the pain mechanism is and where they feel it. And, for a lot of lay people, my mom, as an example, she doesn't have a medical background, clinical background. Anything below her hip and above her ankle would be considered her knee. And so as we're trying to localize, what do I think is contributing to the problem? there's a lot of other stuff beside the osteoarthritis. And I know a lot of patients will come in, they say, well, my doctor said on bone. I was hiking, this trail and I was going up my incline and I was fine, but on the decline, I had a little bit of soreness. So because of the imaging and the pain, they said I should get a knee replacement. I'm like, I don't know if that's really the best time for a knee replacement. Now, for me, I look at the mechanical, how the knee is doing on a mechanical basis. There are knees that just have started to degrade to the point where they're either varus or valgus, which means you're either bow-legged or knock-kneed, your knee is collapsing. Get a knee replacement if the knee is mechanically unstable. Get a knee replacement if there are significant bony changes and you cannot function to do the things you need to do on a day-to-day basis. But to go through the pain, the recovery, the risk of infection, the risk of complication, just because you're fully functional but your knee hurts, that is not, in my opinion, usually the right time for a knee replacement. So I have a personal bias toward mechanical issues over pain sensation when it comes to getting a knee replacement.
I mean, that makes total sense. And if I look and reflect on the patients that I've worked with who've had knee replacements, knee osteoarthritis doesn't happen overnight, right? It's not something where, you twist your knee and all of a sudden you have like this crazy osteoarthritis. The same thing with that, that example you were talking about, like here's this person who was hiking. Right, they were hiking, they were feeling fine going up, but then their knee was a little bit sore. It's not like all of a sudden that osteoarthritis appeared. It's always been there, right? And it's just a normal process of aging. And so I really appreciate you saying, if it's just pain, it might not necessarily be the best time, but if there are true mechanical changes, and that's actually the same thing that I ask for people. I recommend to people when they're saying, should I actually get this knee replacement surgery to begin with? And I find it to be so interesting because especially out in the setting I'm at, I do some home visits out here in California, and I'll actually see people post surgery, actually, like maybe 3 days to a week after surgery. And so by the time I see them, you're having at least 3 to 5 years of some sort of degradation, which led to the surgery. And then here I am trying to rehab them. But I think it's particularly useful. A question that really comes to mind during that time was, all right, well, if we know that it is more of a gradual development of the mechanical changes, what's interesting is that I asked, actually, have they had any sort of physical therapy or work done prior to the surgery? And more often than not, I would say about 75% or more actually say no. They probably had a couple injections here and there, but when it comes to working with the PT or being able to focus on actually just trying to avoid surgery, that mechanical knowledge and being able to just strengthen and focus on actual how the knee works, I haven't seen that much education on the realm on the prehab or the pre-surgical standpoint, really mostly on the back end. And so let's talk about in regards to the journey of a knee replacement, right? Like, so here we have someone who has knee pain, and there's a whole slew of things that patients need to go through before they actually get their knee replacement. As we said, it could be between 3 to 10 years of being in extreme pain and also having some sort of mechanical issue. Walk us through what that journey is from the moment where the patient is like, okay, I have pain, to the moment that they see you and me, or even, to the moment that they actually join your support group and say, okay, here I am post knee replacement.
Yeah, I think, and I want to go back to the last point before I get onto that is, I know understand like all the new information around pain science and how pain is an experience and the whole biopsychosocial model of it. And so when I'm talking to a patient pre-op, and we're trying to get a sense for what's going on, what's the expected outcome, what are you hoping to achieve, why are you getting the knee replacement? Some of the information that I tried to gather is, do you ever have a good day? Are there days that you feel great, you do everything, but then days that you're not feeling so good? Can we pull some patterns together? I know for myself personally, I'm 49. I've got a history of some left thumb degenerative changes and some left knee degenerative changes. There are some days I'm going to wake up, my left knee is going to be swollen, inflamed, painful, but literally 48 hours, it'll go back to normal. Now for me, I know that if I go to a birthday party for one of my kids and I eat some cake and I do some other things, my immune system is going to flare up. I'm going to be dealing with orthopedic pain, even though it's a chemical problem. But once I go back to a normal diet, better sleep, everything's going to clear up and I'm going to feel good again. Here in Ohio, we've got full-blown seasonal allergies going. My eyes are itching. My nose is running. My left SI joint hurts. But it's just because of the immune response I have to what's going on with seasonal allergies. So I think an interesting experience, and you might have had this too, is when you do see a patient who had a knee replacement on the right, and they're scheduled potentially for a knee replacement on the left, but they go through the rehab process for the right knee, and we do everything bilateral, and all of a sudden their left knee is feeling 1,000 times better, functioning better, moving better, feeling better. And a lot of times some of those patients will put off that surgery maybe for another couple years because the mechanical integrity of the knee is still pretty good. It was just the chemical changes that was producing this pain response that now they thought, oh, well, I see it on an image and I feel pain, I need to have a knee replacement. But there are so many other factors we could bring in between lifestyle, stress, food, sleep, all of these things, we can have a big impact. And so going to your current question, the progression of, from being a 20-year-old who could jump off an 8-story or 8-foot ladder to being a 45-year-old who can't run a mile, I think it's the same thing. I think we see this progression of, yes, we have degenerative changes that are present on imaging. I think we have deficiencies in the ligaments and the structures of the knee. Usually I'll assess a knee and it's a little hyper mobile. Maybe somebody ruptured an ACL and didn't even know it. And now that knee is more mobile than it maybe should be. And the person is not feeling as secure and confident in the stability of their knee, but they're still otherwise fit. They're still hiking and biking and traveling and doing all these things. I think we used to say, wait as absolutely long as you can because we don't know how long these knees are going to last. Now it's kind of turned the corner and now we're like, well, maybe don't wait as long. Don't rush into it. But if you get your knee replaced, if you know you're going to do it a little bit sooner, the recovery process might be a little bit easier because you're a little younger, you're still a little fitter. It really has to be a decision made between the team being you, the people who care about you, your spouse, your loved ones, anybody around you, your surgeon. And in an ideal world, your physical therapist would be involved with that decision. Everybody brings information, but you, the patient, are ultimately the only one who can make the decision.
This brought up an interesting thought in my head, and I've come across this probably over the past, say, 3 to 5 years. And as you probably have noticed throughout your years of practice, like every year of practice that we do, we get, a little bit more wisdom, and especially when it comes to recognizing those patterns. And I always found it to be so interesting that even on the prehab standpoint, patients aren't really using or educating, say, a cane, a crutch, or a walker. But then the moment that they actually get the surgery, they're using a cane or a crutch or a walker. And I've been assessing the effectiveness of just trying to understand, pain is in fact an experience. What if we ended up educating patients on using like a cane or a crutch or a walker a little bit earlier in the process? So say, for example, we know that it's actually a lot of pain when you're actually bearing weight through that left leg. Well, why not give you a crutch to actually only to start off maybe about 50% body weight? You'll still be able to move around a little bit more. If the crutch is fitted in the right height, then we can actually keep the gait you're walking actually pretty normal, right? Because one of the things I really noticed is that if you've been dealing with pain for 5 to 6 years and you're limping for 5 to 6 years, not only have you developed an entirely new walking pattern, which we're going to have to relearn anyway post-surgery, but why not make that experience a little bit more pleasant and keep things a little bit more normal? So anyway, that was like completely off topic, but I just thought that would have been a really cool experiment. And I've noticed it significantly, we can, even in the concept from pain science standpoint, a large part is we talk about graded exposure, right? To be able to say, all right, well, if we know 100% tension or 100% exposure causes pain, well, what does 50% do? Does 50% allow you to actually walk normally with a lot less pain? Oh, okay, well, maybe It gives us an opportunity to possibly ramp up eventually to a 100. And, there's a whole slew of events out there. And I think that's one of the big challenges, especially from a prevention standpoint, is the fact that there are, in fact, so many factors where it is very, very difficult for us to actually say, if you do this, we prevent that. I think there's only very, very few scenarios in the medical community in regards to us knowing that from a prevention standpoint. We know one thing, and I've seen this a lot specifically on the LinkedIn standpoint, but look at smoking cessation, right? Like we knew that if we stopped smoking, there was a significant reduction in the various different cancers and illnesses associated with smoking. And so I just found that to be so intriguing. So anyway, had to put that out there into the ecosphere, Tony. And
well, let me talk about that, because I love that. This is where we really get to geek out a little bit, and this is where I can say, from my evolution as a clinician, my ideas, my philosophies, all of it has changed so much. So I think, and I'm going to presume a couple of things here. I think most people are still thinking it's a binary decision. I deal with the pain or I get my knee replaced. That's it. There's nothing else in between. I also think part of the problem is fear of dependency. So, well, I don't want to use a crutch or a cane because I'm going to become dependent on that. And if you would have grabbed me as a clinician early in my career, I would have agreed with that. Today, I'm going to say, that's crazy. If you used a cane to improve your ambulatory quality, you're going to walk more. You're going to feel more confident. You're going to unload that a little bit. You're going to walk straighter. You're going to do better. Like, you're probably going to be better with that cane, with a crutch, with a walker, whatever you need. Then the idea of saying it's not all or none. Let's find that graded exposure. I can't deadlift 300 pounds today, so I'm not going to go for that, but I'll go for 200, right? So if I know I go a mile, my knee is going to be swollen and flared up for the next 48 hours. Then I'm going to go a quarter mile. I'm going to go less than 50% of what I think I can do, test it. Once I determine I did a quarter mile, no problem, I'll go a little bit more. And then each time I'll go more until I hit that threshold where I went 0.6 of a mile and that was too much. Okay, I'll step back. I'll go a half a mile now. And this is what I'm going to do. And this is how I'm going to work on it. But I don't know if it's in healthcare, clinicians, providers don't have the time. They don't think the patients want to do it. I don't know where we lose it, but this is what we do in fitness. We find the threshold, we push past it and then come back below it. That would work in this same exact situation. I even said for rotator cuff, I used to do a lot of rotator cuff repair surgery, rehab. And I was like, what happens if I just put you in the sling? I take the 12 weeks. We do everything exactly the same way as if you had the surgery, but we don't do the surgery. And the resistance I got back from a lot of clinicians, which I understand is, well, if you immobilize, you're going to ruin the joint. Well, what if we don't immobilize 24/7? What if we still do the rehab and the mobilization, but we protect the painful shoulder and recover during that process? I bet a lot of rotator cuff repairs could be avoided. So same for the knee replacements.
Yeah, absolutely. I think I think it might actually be just like the overall power dynamic in regards to just like what the rehab setting is. And I think this is an entirely different discussion in itself. But especially like here we are in 2024, there is a good amount of out-of-network providers now and people who have to pay cash. And I think what's really interesting in that realm, those folks, have a little bit more time to actually be able to take care of the patients. But also, I think from the out of network and cash pay clients, they also have to market and sell. And so because of that, I think it's extremely prudent for them to be able to like really map out the plan and get like the initial buy-in from the clients. It's a little different in regards to the dynamics, we'll say even 10 years ago, where when you're using your insurance, like you kind of go in, it's like, okay, doctor says this, I'm going to go ahead and use my insurance. You weren't necessarily a conscious consumer of the healthcare, right? And so what ends up happening is you go in just because it's like, all right, well, if it's already paid for, I'm just going to go.
Yeah.
As compared to this state in this current day and age where people are going to be a little bit more conscious in regards to the practitioners that they work with. And I know that was actually particularly interesting with me when I transitioned out of the insurance space and be able to say, all right, well, let's create these goals, these exposures, like specifically on you, and, you know, being able to set those thresholds because, yeah, you might have noticed. I mean, in my first years as a PT, I was like, all right, well, I know that this patient is going to come to me for 12 weeks. I can actually just create some of these arbitrary goals because in a way, they don't really have a choice. Or like even if they do have a choice, what's great is the fact that I'll just fill it up with another client because I'm just going to have a huge influx of clients as compared to, all right, let me be a little bit more conscious as to my interactions with these patients so they can stay for the actual desired plan. So that's one of the things I've noticed. And so I really appreciate you bringing that up. So let's talk about the surgery. So here we spent some time talking about how, we may not necessarily need the surgery. There's a lot of things that we can do that can get people prepared for surgery, also possibly even avoid surgery. But for the listeners who are kind of at the point where they're, okay, my scheduled surgery is going to be in the next week or so. And I'm really excited because I've been living with this pain for such a long period of time. Might be a little too late to go through the prehab process that we were talking about. So here they are. What can they expect on even just the days leading up to surgery? And then also the moment that they open their eyes from surgery, they're in the hospital. What happens there?
Yeah, so I think a big part is planning. Those first couple of days before surgery, you want to get as much off your plate as possible because you really do want to be able to just focus on and enjoy the recovery process. Humans are designed to do hard things. We're designed to challenge ourselves, and this is a hard thing that's going to challenge you. You're going to be sleep deprived. You're going to be uncomfortable. You're going to, have these things happening. So I try to encourage all of my patients pre-op, get food taken care of, figure out, you might not have an appetite, but figure out who's going to be doing meals. Are you going to do frozen meals? Like, what are you going to do? Get your little recovery den ready. A lot of people will spend time in a recliner, but even if you don't have one, a bed, a couch, just someplace that's yours that you're going to recover in. And then just understand, if I need to go to therapy because home health isn't coming to me, who's going to bring me? The less stress you have after surgery, the better. That day of surgery, every surgical center, every hospital is going to kind of prepare you. They're going to tell you what meds to take, what not to take, what to do, all of that. But then that first day, most of the patients that I talk to, whether they're my patients or just individuals that have had knee replacements, they kind of report a similar experience. So day number 1, you get your knee replaced. You're usually discharged to home. That's the most common scenario nowadays. If there's medical complications, you might stay inpatient. You might go to a rehab center, but most are going home. You're going to be under the anesthesia. You're still going to have pain management, doing a really good job. It's usually day 3, based on my polls of patients who have been through the surgery. Day 3 is the toughest because you're not sleeping well. The original initial pain meds are kind of out of your system. Now you're relying on what they prescribe for you. And so you're frustrated, you're uncomfortable, the stiffness, soreness is really kicked in. You're dealing from not just the knee replacement, but all of the stuff around the knee replacement. But you have to know there's a light at the end of the tunnel. No matter how bad it might get, you have to know that day 5 is going to be better than day 3. Day 10 is going to be better than day 5. And now you're going to start kind of that recovery process, that journey. For my patients in my physical therapy clinic, I usually see them within 24 to 48 hours post-op. That first session, we hardly do anything. That first session's 20 or 30 minutes. I ask you a couple questions. I get a sense for how you're feeling. I know you're going to feel nauseous. I know you're going to feel weak. Some patients get anemic. I'm going to just look at the incision, give you some peace of mind, let you know that everything looks good. This is normal. The swelling, the coloration, everything makes sense. You're in good hands. I'll show you 1 or 2 things to do and you're done, and that really, from my perspective, is what our job is as therapists. We're there to support, we're there to provide you that encouragement and really give you that sense of peace of mind so that okay, everybody, things are okay. No red flags. Now, I know different treatment philosophies exist among different therapists, different surgeons. There are some surgeons that want 90 degrees of flexion within the first week or two. I tend to be a little more laid back. I tend to say, look, as long as you're improving, as long as we're making progress functionally, you didn't get the knee replacement to achieve an arbitrary number on a goniometer. You got the knee replacement to improve the quality of life. So let's focus on that. Are you able to get up and down a little easier? Are you able to do these things a little better? As long as that needle is moving in the right direction every day, that's it. I don't care if it's happening within the expected guidelines. Your body doesn't care about those time frames. Your body is going to recover when it's ready to recover. We're just here to kind of join you on the journey.
Beautiful. Yeah, it's important. I'm glad actually that you said that it was the journey of what it's like in regards to kind of getting, waking up post-surgery. I mean, you're still having the anesthesia in you. And, one of the interesting things that I've come across is that patients actually feel pretty decent. Upon opening of their eyes, they're probably feeling a little groggy. And I would say it's kind of 50-50. It's either patients are feeling great and then they push themselves way too hard. Or the second option, what I found to be particularly interesting is the fact that patients feel okay, but they don't know they need to kind of sit up. And yeah, it's around that 3-day mark where they're actually feeling the worst, which I find to be really, really interesting. And oftentimes when I'll see someone on day 1 or 2 post-surgery, I'll say, listen, from days 3 to 10 are going to feel pretty miserable. And what I found to be particularly interesting is that once I tell them that they are going to be feeling pretty miserable, the interesting thing is the fact that because I forewarned them, it's actually not as bad as they thought, which I found, and it might be anecdotal evidence, but telling them, hey, you're going to be in the worst of it in the next 48 hours, and it's not as bad. It's much better surprise versus, hey, you're doing great. The next day they're feeling terrible. So, and I really appreciate that. And I often tell people, listen, the first 2 weeks is we're looking at infection prevention. We're also looking at blood clot prevention, just getting you moving. And it's a brutal surgery. I mean, once they close you up, they're playing your knee like an accordion to make sure that it's all in line, right? It's pretty beaten up. And I mean, it's very different compared to the people who've had, say, hip surgeries. Hip surgeries, they might be a little sore a few days after, but in regards to feeling not the greatest, that's where that's where the hip surgeries recover a little bit faster than those knee replacements. And so we have like this overall process, and it's definitely recommended that you're working with a PT, that you continue to do your movements and knowing that there is going to be a progression of the activities. And for the most part, people are going to go back to their normal day-to-day activities. I was speaking, you said you were from Sarasota, Florida. I spend a fair amount of time, not in that part of Florida, but like Southern Florida down in like Jupiter. And I'm playing, pickleball with retirees who've had, both knees done, and they're looking great. They're pivoting and they're doing all this activity. So there is a lot of life that is actually available and that people can truly live post these knee replacements. So it is a very powerful procedure, and I'm really glad that it's there, and I'm glad that we have people like you and me who can actually help people like get back into it. Now, physical therapy and movement is a large part of it, right? So there's a lot of different ways that you can actually receive care, right? So you have your online support group. There is in-person physical therapy. There's a lot of different professionals that are out there. So let's talk about the selection process, right? I know that in my town, there is probably 20 plus rehab clinics, either single practitioner or multi-practitioner as well. Tell us a couple of qualities that we should be looking for in regards to trying to find the right practitioner for you and for the procedure.
Yeah, I love this question because this is something that I've taken on personally for over a decade. I think about matching the right clinician with the right patient. Now, even within my own personal organization, a patient gets referred to us for whatever the condition is. I try to match the personality and the desires with the right therapist, because there are therapists who specialize in manual therapy. There are therapists who specialize in sports performance. There's so much variety across clinicians, but there's also so much variety across personalities. My personality is very different than two other clinicians that I work with. And so if we don't match those personalities, I think we do a disservice to the patient coming in. In an ideal world, the patient would understand you have the choice. It doesn't matter if your doctor sent you to, physical therapy at this location or that location. You always have the choice to say, this is who I want to work with. This is who I want to see. And now with social media, with YouTube and all of these platforms, you really can get to know your therapist pretty well. So I had mentioned earlier, I've got a YouTube channel, lots of views, lots of interactions. My goal for that is to educate and inform, but it's also to help the patient understand there's different ways to recover. There's different ways to connect with your therapist. I'm never going to be a drill sergeant kind of therapist. I'm never going to tell you to push through anything. I might not get you to the functional performance that another therapist might get you to, but I'm going to make it far more enjoyable along the way. So if you're the kind of patient that wants hands-on manual therapy, wants to connect one-on-one, wants that interpersonal connection, you should find a therapist who can deliver that. If you're the kind of patient who wants more of a group setting, you want to see what other people are doing, you like to socialize, you like to go in and it's more of a pub environment, a family dinner table, you can find that. I created a website called chooseptfirst.com because I wanted patients to be able to choose who they are working with. And even you and I, before we started recording, we talked about background in martial arts. We talked about jujitsu. I didn't realize that you were out in California, but I used to go to the Inosanto Academy in LA a lot. And it's like that instantly creates a connection between you and I. And I think patients should have that same kind of connection with their therapist, because not only does it provide a better patient care experience, but you also understand each other better. You trust each other better. And if we're talking about pain, you said just a minute ago, if you tell the patient what to expect, the patient can handle it better. That's, all so much of pain science is understanding the context of the situation. When I tell you what to expect and that it's normal, that there's not something wrong, I find that my patients are more comfortable. They're more confident. They're more secure in what's coming down the road. But you can't do that if you don't trust your therapist, if you don't communicate well with your therapist. So yeah, that choosing who you work with is probably going to be one of the biggest factors in having a positive experience.
Love it. Yeah. Ultimately, when you are, physical therapy, in essence, we're a service. Like, yes, we have the knowledge, but really it's being able to take that knowledge and apply it to English, kind of like what this podcast is doing, but ultimately being able to formulate a relationship. And it's that relationship that allows you to really get the most out of the time that you're spending either in the clinic, at home, or wherever you're at. So, Tony, I really appreciate that specifically because, I think a lot of times, especially now, or just talking with more folks, is people will be like, oh, okay, well, my physical therapist is okay, but I'm not really vibing with them. And as a result, what ends up happening is because they're not having that true relationship, compliance might be a little bit more of a challenge. The adjustment might be even more of a challenge. It ends up just being more of an uphill battle, which I'm, especially at this point in my life and career, why, things are already hard as it is. Why make things harder and more challenging? And, why make that more difficult for us? It is important for, us to be able to, in fact, pursue hard things, but also when you're going through something as difficult as a knee replacement, might as well make your experience better than just having to live in pain, stiffness, and discomfort. So I really appreciate all that. Tony, you actually, tell us again a little bit more about your YouTube channel, your communities for knee replacements, so the listeners can actually go on if they're considering either getting a knee replacement or in the thick of things and want a little bit extra support.
Yeah, so you can find my YouTube channel by searching Total Therapy Solutions. You can also just search from my name. All of the content is obviously free. I've answered just about every question I've been asked, because the way I look at it is there are millions of people that are never going to be in Ohio. They're never going to be my patient. They're never going to come work with me. And the information for me to give it to them is totally free. There's no reason why I shouldn't answer questions. And these could be questions from, I'll get a patient that comes in and their water resistant dressing has perforations. And so it's no longer water resistant. And they're not sure what they should do, or they're not sure how to position their leg, or they're not sure if the swelling at the level it is normal, is okay, or if they need to go to the emergency room. All of these kinds of things, we answer a ton of those questions, long form, short form video. The website Choose PT First is a directory website where you can go and put in your city, state, and you can look for therapists that are in your area. It's not total knee replacement specific, but it gives you a chance to kind of see who else is around. But my most important part in all of this is just trying to give the general population a peek behind the curtain. We have to protect patient privacy. We want to protect the relationship between the therapist and the patient and what's shared. But at the same time, if you don't know what's happening in 3 other clinics in your area, you don't know if you're getting good care. You don't know if you're getting bad care. You don't know if this is normal. You don't know any of that. And so my objective for, like I said, at least 10 years, probably closer to 15, has been, let's let the public see what exactly we do. It's not just about stretching hamstrings, although that's important at times. It's not about, no pain, no gain. It really is the closest thing to, we're there to coach you. We're there to provide that support, provide that education. Although I've never had, and this is an important element, I have never had a knee replacement. I openly acknowledge and admit that. I can never put myself in your shoes if you just had a knee replacement. The best I can do, though, is I can give you experience from probably 1,000 knee replacements that have happened over the last 20 years that I've been in the clinic. I can give you access to their experience. And I can tell you from what I've seen them go through, I can provide you with information about what you're going through. And so that's what I try to convey in my social media and my videos and my articles and anything that I deliver.
Beautiful. Yeah, listeners, I'm going to go ahead and put those links into the show notes. This is a really great resource. You're right. A lot of us physical therapists, especially at this point of our lives, haven't gone through a joint replacement. And so although we know a lot from the technical aspect, living the experience is an entirely different process. The good news is the fact that when you have experts like Tony, who's seen thousands and thousands of these knee replacements, he has a pretty good idea of what's going on. And especially a large part of physical therapy is, one, it's pattern recognition, but in addition to that, it's being able to put the pieces together so you get the best care that you need to. And Tony, I really appreciate you saying that it is important for us to actually kind of open up the curtain, kind of show what's going on. I had an interview with a spine surgeon, actually, probably about 2.5 months ago. And he was really a brilliant man. He was really kind enough to say, hey, listen, I want to know what you're doing in the clinics that are actually taking care of your patients. Because, and interestingly enough, a lot of practitioners don't really quite know what the other profession's doing. They're kind of looked at as a black box. And so what ends up happening is that because it ends up as a black box, we kind of get grouped all into like various different silos, right? And yes, in a way, when you get grouped in various different silos, it makes the selection process a little bit easier, but also people can get entirely misinformed, right? Which is one of the reasons why we have a podcast like this, is to be able to say, let's go ahead and open up the curtain. Let's make it known that our care is helpful, but it's not a black box. And there are a lot of different things that we can do to take care of the folks. So Tony, thank you so much for your time today. This was really, really cool. And I'm just excited to be able to share more of your knowledge with the listeners who are either in the depths of their knee replacement or are looking at getting the procedure done.
Absolutely. Ashley, thank you so much for giving me the opportunity to come and share my stories and my experiences. So I appreciate it.
No patient-therapist relationship is formed by listening to this podcast. We are not providing medical advice, and all information should be confirmed by a medical provider.